Amit, if I can ask you one clarification. Beautifully, you showed that posterior is going from one side to the other side. That's a fracture which is known, which goes from lateral side to posterior malleus, and it involves the medial malleolus also. Have you found any difficulty in reduction of that? Because, as I said, if you reduce them separately, they will not get reduced. Have you got any option? First, you put a posterior malleolus there from the lateral side, then you put in the medial malleolus from the medial side. They will not, because there's a one piece which goes there. So that one piece which goes there, I had been through the cycle where I fixed up the posterior malleolus and then went to fix up the medial malleolus. Since it was a one piece, medial malleolus won't fit in. So I had to remove the screw of the posterior malleolus and simultaneously correct the displacement. Hold them with the KY, with the tongs. Once you have reduced the whole fragment, now you can fix them up. Otherwise, if you already fixed up one and is not fixed up into 100%, other one will not fit. I think we have discussed this and you have been through that.
Absolutely correct, sir. Because, but I like to tell you that this, as I told in my lecture, that this posterior-medial type is more or less broken in the middle. It is a continuous fragment, but there is a small split over there between a posterolateral and a posteromedial. But the posteromedial fragment is a very big, large fragment. The posterolateral is a slightly smaller fragment than the posteromedial. So I go more or less more. First, I take an incision on the posteromedial side, buttress it. Don't fix your medial malleolus from the normal medial malleolus incision at all. Only that posteromedial buttressing gets your posteromedial reduction. And if need be, go on the posterolateral side again, or a small a small guide wire with a cannulated cancellous screw on the posterolateral fragment is also more than enough.
How many of you still believe 5%, 10% of the posterior malleolus doesn't need fixation? When do you decide you have to fix up the posterior malleolus or no?
Literature says that more than 30% needs fixation.
The literature which was written, which was Campbell, which is the last 12th edition, Campbell, which is now 5 years. You are not fixing up the posterior malleolus bone. You are fixing up, as very beautifully he explained, posterior tibiofibular ligament. And that is the one which is a very strong ligament for the syndesmotic stability. So today the situation is, it may be an overkill, but if there is a posterior malleolus, fix it up. So that you will 99% of the time, if you fix up all the things, you won't have to put the syndesmotic screw.
For last 5 years.
Yeah, so because all the literature has come up now, so the textbooks are not valid.
Thank you, sir. For the next session, I'm inviting Dr. A.K. Dubey, Dr. Bhaskar Banerjee, Dr. Harihar Singh, and Dr. Bindu Sharma sir to please chair the session. And Dr. Govind Patel sir to please chair the session.
she was obese and hypertensive too. So the index previous surgeon operated this by doing PFN. So I don't have a immediate injury X-ray. So something we can appreciate on this that there was a breach in the lateral cortex, and there was an intertrochanteric and line and intertrochanter is also communicated, and probably I don't have a lateral view, but in the AP view we can appreciate that the lateral view might be fine. So then the patient started weight bearing with the help of walker at 2 months, and then she developed while walking in the 3 weeks while walking, she developed pain. So this was she went to the clinic of that surgeon, and this is the 3 months post-op. So you can see that at this 3 months post-op period, the screw, the proximal derotation screw of the PFN, it is protruding the joint, and also you can see that there is that lateral cortex, lateral breech is also displacing. And any comment on this till now? If anyone like to comment on this, this is at 3 months post-op. Okay, sir. Sir, then at 8 month post-op, patient started walking without walker, and this at 11 month post-op, she developed a severe pain in hip, and the shortening also increased. So she went.
You think that is the cause of the problem?
No, sir, the cause of the problem was the union. So she went to his clinic, and X-ray was done. This was in June 2022. So this was the X-ray.
If you go back first,
Yes, sir.
and you see the point of entry, which I was talking about, it is in the tip of the trochanter, it is not in the piriform fossa. And then the reason you got a varus on day 1.
Yes, sir. So the entry, as Dr.
And you have also broken down the GT, because you have been to the point of entry as in the GT. So all the lateral column of the GT is broken. So it is day 1 instability.
Yes, sir. And Tanna sir, that newer PFN nails, which has a buttress plate along with PFN, some buttress plate is coming. That will buttress. Is it helpful for the lateral?
Very much. For this situation, it will be helpful, but you got a virus which is not acceptable to me.
So that
if you go to the piriform fossa and then put in a buttress plate, that will be perfectly all right.
Okay. So
still today also that will be the treatment.
So when the fracture is comminuted in the intertrochanteric and GT area, how we can determine that your nail will go in the piriform fossa? Tanna sir, how will confirm that if in case of comminuted intertrochanteric and GT fracture, that your nail is going through the piriformis fossa?
Siam will give you that view. And in a very obese patient, it will be difficult to do it. So do it in lateral position as I showed you that. Otherwise, in a Siam view, into average position, you'll be able to know exactly where you're going. Then the nailing is contraindicated to me.
Okay, sir. And your hook plate is superior, or this lateral buttress plate is superior along with PFN?
I think laterally what you put in is going to give you a good stability. I don't know, insist on a hook plate or whatever plate you like.
Okay, sir.
I use a hook plate, that's for a different reason, because I feel that proximally there is not much enough hold of the other things in the screws, so the hook really holds you down there. So you virus correction almost exclusively, and the GT, which is under the influence of an abductor muscles. So if you put in a side plate, the abductor muscles are still working to really displace the GT. Then there is the hook you down, that abductor force will be neutralized.
Sorry, sir, this was, when the patient was with previous surgeon, I could only collect this. And one thing I forgot to tell that when, at the 3 months post-op, when the patient went to the previous surgeon, the surgeon told the patient that I want to change or withdraw the screw. So he took her in the OT and he either exchanged or he withdrew the screw. And again, with a gap of 1 month, he told the patient that you can walk now. So with the help of walker, she was walking. After this, when the proximal screw was migrating in the joint, then the surgeon exchange or withdraw the screw. So this was at 11 months post-op. Then the patient had severe pain and shortening. So what are the treatment options? Either we should remove obviously we should remove the implant. Either we should redo the osteosynthesis with the help of FNA2 or a better implant, or a proximal femoral LCP with bone grafting.
Please, if I can correct you, FNA2 is not magic. It's one of the variations which is there available for a PFN. FNA2 has been proved to be a little more complication based than the screw based. Because of the sharp surface, it can penetrate inside into the neck. There is enough evidence to that. It's very beautiful to do it, it's very exotic to do it, but it has not proved to be anything superior to any of. Found it to be exotic to use it. वो जो instrumentation and all सब इतना fancy होता है, अपने को अच्छा लगता है. मगर the functionally, the one screw or two screws and helical blade, it doesn't make a difference. The helical blade has a tendency to go inside because it is sharp one.
And screw has not chances of cut through, sir, instead of in geriatrics, sir.
Screw will cut through, helical blade will cut through. That's not the issue at all. If it is now with the screw or a helical blade, you put in a cement which will give you the stability, that is a different ball game. That's the one which is still to be worked out. I don't think there is enough material on that. But that seems to be more attractive into those porotic bones.
So, till now, sir, what treatment option you will prefer, sir? Please comment. Either arthroplasty, you will prefer, some surgeon may prefer arthroplasty doing
How old is the patient?
So 64 she is now. 64 year female.
And she can leave a table and chair and commode life?
Till now, sir.
Is she in the socio-economic structure where she can leave a table, chair and a commode life or no?
Yes, sir.
She is well to do, she can live like that.
She is a normal housewife. She is. No. She.
पालकी बांध के बैठना पड़ता है वैसा नहीं है.
She is not. She doesn't insist that she wants to sit on the ground.
And she has a commode in the house.
Yes, sir. She has. So, should we prefer a total hip replacement or a valgus osteotomy fixation with a double angle DCS or a blade, or you should leave it her as a conservative, because she has a lot of comorbidity also, diabetes, uncontrolled diabetes, and a very chronic UTI patient. She was taking cefuroxime for 1.5 years for the UTI, and hypertensive, obese. So
and the replacement is a high risk situation. What you have proposed here is the valgus osteotomy with the DHS will be still a better option. but you got to have that valgus correction and probably the hook plate or a tension band wire in order to correct the virus.
And sir, how will remove that broken screw that in the head? Any comments, sir? During the implant removal, how will remove this broken proximal hip screw? Okay. Please take
If
my.
you have a phobia of removing, sorry, somebody talking about it.
Dr. Anupam, please take mic.
If it is lazy in the superior cortex of the head of the femur, it's not necessary to remove. If you are intended to remove, then you pass it through the guide wire under the C-arm, and there are the screw remover. You can hold it and you can take it out.
Hold it with what? Under C-arm.
If you are passing the guide wire under the C-arm through this screw,
Through the broken screw.
through that hole of that nail. The nail is a hole there. You have removed the hole of the nail and this screw, distal part of that screw. So there is a hole in that cortex.
Yes, there will be
You
a
can
hole.
see. Then you can pass the guide wire.
So through the hole of, after removal of the PFN nail, through the hole of this implant, we should manipulate the guide wire inside the broken
Exactly.
screw.
Yes.
Then we'll extract with what?
The entire exercise depends on what you are going to do next. You may leave that.
You need to remove with that.
So many times we do surgeries and we leave a broken screw.
There is a hollow meal are there to remove with the size of it.
What is the point of the entire exercise? You first decide what you are going to do next.
It's
What
not
are you going to do
necessary.
next? What is your plan?
Yes, sir.
That it depends on that. If you are going to do something,
Yes, sir.
Asking what it will be our plan now. But what I feel, 64-year-old lady, again you are going to make an exercise to make it unite. Well, if it doesn't unite, 3 months you will, or 2 months you will keep in bed. And early mobilization is the one that is needed. So why not to take out all this gimmick and do your sort of bipolar or THR? Broken screw, that is what the region. You take out the screw with the neck, the broken screw will be out in the air. We are going to do her arthroplasty. That is the best answer if she can afford.
Yes, sir. So you prefer a total hip replacement or a bipolar?
Well, depends upon, I would prefer a bipolar. I have got my own bipolar for which I will be talking that provides sitting and squatting. So sitting and squatting was the need, what Professor Tanna was telling, that what are the economic and socio-cultural, scenario. So in that situation, probably a bipolar would be a better option. And if that survives 20 years.
Simple bipolar or a long revision step?
Yes, a longer step.
Long step.
But even the simple with cement will do. The simple with cement will do. But the only problem is that, how are you going to, because the calcar is not there. If the calcar is there, it's good. If not the calcar, that is going to problem. You will have to use a modular side of scenario here.
So there is the calcar, I think, is broken, sir.
That is why you need some kind of modularity and to keep the length and to maintain the length. A cemented one, or preferably.
And so with bipolar, how the proximal screw has already migrated the joint. I showed in the previous X-ray, sir.
Yeah, but you are going to take out the joint, you are going to take out the neck and the head, and with that, the things will come out, won't it?
Okay, you will prefer a bipolar for a THR.
I would prefer a bipolar, preferably, because the joint the cartilage is there. I know that a lot of people will go for THR. But then you have to see the patient's clinical condition, morbidity, comorbidity, etc. And economy. And the cultural scenario, sitting and squatting. Not many people allow sitting and squatting after a total hip replacement, which is a need at least in our area, in our country.
So any other option which anyone, any other surgeon would like to say? Please give mic, sir.
Dr. Imran,
Yes, Dr. Amit as well.
please show the next slide. What have you?
What have you done? Okay. So I planned a valgus osteotomy, and I planned a 120-degree plate. I took some angle. This 30-degree wedge I plan to remove. Then this was Siam AP view. That after implant removal, during the procedure, that broken screw that got rotated and it went anteriorly. So it was out of the way of this blade. Then I didn't remove that broken screw. This was AP view. This was lateral view. You see that the broken screw has migrated anteriorly. So it is not coming in the way of the implant. So I left it there. This was immediate post-op AP and somewhat oblique view. You see that osteotomy was done and the varus is corrected. This was immediate post-op X-ray. And this was at 1.5 months. You see that some callus formation is there, and the implant is good and stable. Then this is at 3 months. You see that at the osteotomy area and intertrochanteric area, the callus is there. The rest of the things appears fine. This is AP view, and this was a lateral view, and there is a good union going on. And pre-operatively, the shortening was 1.5 inches, and post-operatively, it was just 1 centimeter, which is still not appreciated by the patient. I have not told this. She has a severe osteoarthritis and FFD in the both knees. Bilateral osteoarthritis is there. Video is not displaying there. So still, 3 months have passed post-operatively. I have advised to use walker because of this multiple comorbidities, and she's walking comfortably with walker. And gradually, when I will do serial X-rays, I will remove this walker.
Thank you, Dr. Imran, for your nice case presentation. Now, may I invite Dr. Jayan Sen?
Thank you. Thanks a lot.
Dr. Jayan Sen, sir, to present his case on the fracture, specific fixation on pylon fracture.
So I learned that valgus osteotomy and fixation with angle blade is a very good option to salvage the failed cases of intertrochanteric fracture, and arthroplasty should be avoided in multiple comorbid conditions. Thank you.
Thank you. With the permission of the chairpersons, thank you. And once again, big thanks to Dr. Manishi Bansal and Dr. Tripathi for inviting me here, and to the whole team for providing some very warm and affectionate hospitality. So we'll all leave with very fond memories from here. So So what I'm presenting is not actually a case presentation, but is actually what are the current concepts in the management of pylon fractures, and I'll be taking you through the whole gamut of them and how to manage pylon fractures. Yeah, so pylon fractures, basically you do a staged procedure. So primary close reduction employing ligamentotaxis and fixation of the joints of the hind foot via tibiocalcaneal metatarsal fixation offers a safe basis for consecutive imaging and the selection of specific approaches for definitive reconstruction. So, as has become very popular now, the concept goes to span, then scan, and then you plan. So the time frame for definitive reconstruction is up to 3 weeks after trauma and follows a detailed planning considering the individual dynamics of the soft tissue situation. And definitive treatment, we have a wide range of procedures and implants, and in difficult cases, primary arthrodesis is also a solution. So basically, when you're treating pylon fractures, you have to have a knowledge of multiple procedural variations that are available, and we can work accordingly. The use of CT scan, well, this study showed changed the operative positioning and the approach in 45% of the patients, although there was no significant change in the operative plans. And this is a comparison of the various plates that were available in the market, and all the 3 plates were deficient in capturing the median malleolar fragment. This is a study, of course, from Jaipur, where they treated with a combined limited internal fixation and ankle spanning external fixation, and they found it to be a safe and effective management option. This study from China showed that arthroscopy-assisted minimally invasive therapy significantly improved reduction, result, and bone union and functional status, and decreased traumatic arthritis. In this study, where the pylon fractures were managed by Elizarov, all fractures united, and they concluded that Elizarov is a safe and effective treatment for severe pylon fractures with minimum complications and good healing results. What is done most commonly are the plating and the MIPO and the other procedures. And this study, which looked into 92 fractures and everything about all the variables, concluded that the rates of infection were about 13%, non-union 10.86%, and the infection and suboptimal anatomical reduction was related to a higher rate of fair and poor results. And the anteromedial approach had a higher prevalence of skin necrosis and early post-traumatic ankle arthritis than the anterolateral approach. And the use of medial plate was also related to a higher rate of non-union. This study again from China, and this was concluded that if the surgical approaches were based on the fracture line distribution and bone displacement as revealed by CT scans, they were able to achieve anatomical reduction in 19 of the 25 patients. And finally concluded that all 25 patients had good AOFAS scores and 15 patients were excellent. So back to this patient that we started our story with. This patient, we did primary stabilization with an external fixation, then we did the scanning, and at about 3 weeks we went in and did the MIPO fixation. And this is how I do my MIPOs. So all stab incisions basically, and very minimally invasive. So if the principles are maintained, the plate length is good and you have a good hold, then the results follow. Video. As usual, the video is on.
जल्दी नहीं है हमें
1:30 बजे की फ्लाइट है
11 बजे
तो फिर
सर आप जा रहे हैं क्या
नहीं
So this is the result at 3 months post-op. Incidentally, this patient also had a fracture talus on the other side. So basically, pylon fracture on one side and a fracture talus on the other side. This is a video that the patient sent from the village. She's about 600 kilometers away from us. She lives in Ganganagar. Video close. Okay. So basically, if you look at the various treatment options and there are complications, so if we do have a complication, then we need a multidisciplinary team with an orthopedic surgeon, a plastic surgeon, and an infectious disease physician, and plastic surgeon to clean the wound dehiscence. And that can be limited by doing the minimally invasive surgery, but sometimes still you end up with a very ugly looking ulcer at the site from where you have put the plate in at the distal end. So a concept which has been working in the distal radius has also now been incorporated in the distal tibia or the pylon fractures, and that is the use of mini fragment plates. And they provide a versatile system to achieve these goals, as they are low profile, can be controlled, and offer a wide variety of options for fragment specific fixation because of variable angle locking screws and multiple plate configurations. And fragment specific fixation has already been adopted in the upper extremity. So basically, small incision, smaller plates, and the word of caution here is that the mini fragment fixation should not be used for all pylon fractures. In cases of complete C-type fractures, in cases of metaphyseal combination, larger blades should be used to avoid plate fatigue and failure. And the external fixator should be removed at the time of definitive ORIF to allow for early range of motion. So the last option, of course, is in pylon fractures, primary arthrodesis, and it also gives reliable union rates and spares the subtalar joint. And it's an option when you have significantly severe comminuted injury of the distal end of the tibia. Compression wrapping for post-traumatic edema was effective in reducing the time needed for soft tissues to be appropriate for definitive surgical fixation of pylon fractures without increasing the risk of wound complications. So that is a way of speeding up the time to surgery from the primary spanning to the definitive fixation. So take-home message: the treatment results depend on the severity of the initial fracture and the accompanying soft tissue damage. And good clinical results can be achieved by accurate preoperative planning with respect to the surgical procedure, time of surgery, and the surgical steps. People have used plate fixation in combination with external fixation and minimally invasive articular reconstruction with or without arthroscopy. Complex fracture morphology and vulnerable soft tissue coverage of the tibial pylon are difficult to treat, and complications are common. The early complications are the soft tissue necrosis, persistent fragment dislocations after surgery, and loss of reposition and deep wound infection. One should be aware of the early signs of compartment syndrome and chronic regional pain syndrome. Late complications include bony necrosis with or without deviation, non-union, and ankle arthritis. And finally, in this study, we should take care in virtually every surgery, and that is check for smoking. And procedures that involve bony fixation, that is arthrodesis, ORIF, were all associated with negative outcomes in smokers. Of course, they didn't make much difference in total ankle arthroplasty and amputations. Thank you all for your patient hearing.
Now questions are invited from the audience. Any questions? No. Sir, do you always check all your intradural fragments with the orthoscope during the surgery?
No, I don't. I don't. My way of working is by doing a CT scan and then planning the fixation accordingly.
Thank you, sir.
Thank you much.
Now may I invite Dr. D.C. Srivastava, sir, to deliver his talk on the dynamic kinematics of the metal plate design and its application in the fracture.
This lecture which I have designed was basically for the young generation, and most of the senior people will not have much in it. I have tried to look into the biology of the fracture with the design of the plate. The basic issue is once you make a construct of implant and bone, the structure of the implant as well as the structure of the bone, these two issues, the material property and the structural property, has to be taken into the account to find the end results. The compression of a bone in itself has to be read in the terms of the strain, and that is if it is in an axial manner, it is the reduction in the height versus the length of the bone. And that is the key to look into our unions, because the loading in the axial direction invites the osteosynthesis. Although I just mentioned something which is not being used and told in the books, the osteoblastic cells which come from the endosteum, periosteal layer, as well as in the marrow. The recent studies, and one of the paper by Track has reported in 1942, after the advent of the electronic microscope, that the endothelial cells get into the basic nature when they are acidic once there is a macromotion. These macromotions are in the category of 200 micromillimeter. That has been reported. If it goes beyond that, if it is less than that, the range of motion should lie above 200 micromillimeter to the 0.2 millimeter. Thereby it can invite the conversion of endothelial cells of the vessels into the osteoblast. This is one of the new studies which have shown that also supports the theory of Sarmiento, who told that the macromotions in an axial manner with less setting and with a little angulation leads to the more osteogenesis. This is one of the slides that shows the compression, and then the things has to be learned while you are applying the plate in the terms of stress and strain curves. The stress is something that is what is a pressure here, and the strain which is going to give way to the micro cracks either in the bone or in the plate.